Hi, everyone. This is just a bit of a progress report, really, around where we are at with cladribine in New Zealand. And the work that's been done by MSIF will certainly help with our efforts here. There's around 4,100 people with MS in New Zealand, and the average age of diagnosis is around 38. We have a higher instance of MS in the south of New Zealand than the north, and the latitudinal gradient is fairly strong. The average time from onset of symptom to diagnosis is also around 4.7 years, and we've got that data from prevalence and incidence studies, and hopefully the work that we've been doing in recent years will help to close that gap. The government agency that decides which medicines are funded here in New Zealand is called PHARMAC, and that is who our key advocacy work is targeted towards. In New Zealand, we're very well known to undertake long-term advocacy. In July 2022, we finally got the McDonald 2017 diagnostic criteria approved after 8 years of advocacy. And so we're now seeing that people no longer have to experience a second relapse in order for them to start treatment. This is a huge step for treatment in New Zealand. And through long-term advocacy and through collecting of a lot of data and evidence, we were able to push this through and see a lot of progress. We are quite fortunate here in New Zealand. We have a lot of first-line treatments being those high-efficacy treatments, and they're funded for relapsing remitting MS with an EDSS score of 0 to 6.0. The first-line treatments that we have funded are Ocrevus, Tysabri, Tecfidera, Gilenya, and Aubagio. And we do have some people still on what we call second-line treatments, and those are the Copaxone, interferon, and betaferon. Rituximab is also used here under special conditions, but it is not one of the most commonly used. People aren't generally in New Zealand anymore put onto those Copaxone, interferon, and betaferon treatments, but we do have a significant number still on them from before the first-line treatments were funded. As at June 2023, we now have over 2,073 people on treatment, and the main treatments funded are obviously Tysabri and ocrelizumab, which are kind of longer infusion treatments, which is where cladribine will certainly have an impact. And excitingly, from the 1st of October, we will be having Ocrevus funded for primary progressive MS, which is a huge step here in New Zealand, meeting a very high unmet need for the progressive MS community. And that will be for those with who have never had a history of relapses before and an EDSS of 2 to 6.5. Just a bit of an idea of the funding landscape in New Zealand. We are, out of the 32 OECD countries, we rank 32nd on where we sit for publicly funding medicines. There are 109 applications still sitting on PHARMAC's options for consideration, and to be able to clear that, they need that needs $417 million to clear that, and there's a shortfall in PHARMAC's budget of $181 million. There's medications, when they go through funding applications with PHARMAC, on average are sitting for about 7.7 years in that process. So while PHARMAC are often applauded for getting very low costs for treatments, it can often obviously come at a cost to patients. At MS New Zealand, we strongly support the MS Brain Health Principles and their standards, and the key areas which we see really play into the funding of cladribine are early intervention, shared decision-making process, full range of disease-modifying therapies being available in order to make decisions tailored for each individual patient, and the cost-effectiveness of treatments for patients and their families, as well as that wider health system. In New Zealand, we are currently experiencing a major health workforce crisis, as I'm sure many of you also are. There are significant wait times for neurology appointments, infusion clinics, and MRIs. Anecdotally, we have heard that our main centre is experiencing a 400-day delay in first neurology appointment if symptoms are mild. We have around 50% of the number of neurologists that is recommended for our population, and a third of that in Australia, based off Australian numbers. We are currently waiting for the latest data from Te Whare, who is our Health New Zealand organisation, and they are trying to collect that data for us, but we're currently experiencing a 3-month wait in just understanding what the current situation is. We are a small population of just over 5 million, but we are quite widespread. There is an equity and access for healthcare for rural communities and Māori and Pacifica, and ensuring that those communities in particular get the necessary access to healthcare and treatments is particularly crucial. So why do we see that cladribine is particularly important? It has a very appealing treatment protocol, short duration, it is oral. There is a reduced monitoring, which then reduces the burden on our very pressured health system. There are long-term cost savings to the health system and patient, and improved health impact, quality of life. The latest data that has been made available to us is that around 10% of patients will require retreatment by year 4, and then even by year 5, a huge percentage of them are still not requiring that retreatment. Not only will it impact patients, but also a lot of families. We know that obviously with the infusion treatments, many families and carers have to take days off work in order to take their loved ones to infusion appointments, and that obviously impacts their own working abilities, particularly if it's on a monthly basis. And overall, cladribine will really help to overcome those inequalities in access to healthcare, where people aren't able to access infusion clinics very easily, or whether they are having to wait a significant amount of times for appointments. There's a huge range of identified patient groups that we feel would benefit from cladribine, and a lot of this has come from the research and from conversations with neurologists that we've had. Particularly older people, those with health conditions and those immune compromised. It doesn't seem to have an impact on vaccinations, which is hugely important. Those with both relapsing remitting and active secondary progressive MS. I'm aware that the FDA fund for active secondary progressive MS, and there is a very high unmet need here in New Zealand for that group, with no access for available funded treatments. Patients with fairly stable and lower inflammatory activity it's been notified to us that they would be a group that people would put on to treatment because of the stability and safety of cladribine. Those in those rural communities who have limited visiting neurology services, or limited access to infusion clinics, or who have to travel very long distances for their infusion appointments. Also, younger people with MS are a particular group who we have identified cladribine would be useful for, particularly those who are looking at going on their OE, or who may be considering family planning, obviously not in that immediate term, because you're not allowed, you're not supposed to get pregnant until at least 6 months after your year 2 treatment. And of course, another area which has been identified to us from some discussions by neurologists is the consideration of when patients are coming off some of those higher efficacy treatments, putting them onto cladribine in order to keep them stable for that bit longer. And that's just something that's been notified to us. So where are we with Pharmac? In 2018, Merck, who have cladribine, they made their first submission for funding. In July of that year, PTAC, which is the Pharmacological and Therapeutics Advisory Committee, the committee actually declined the application, but additional information was submitted and reviewed in November 2019. PTAC at that time then did recommend funding, but only if it's cost neutral to Gilenya. So by that, they didn't want to be spending any more than what they were currently spending on Gilenya. Merck then submitted two, I think, by that time, pricing applications, which were then declined. They have made a third one since, which has also been declined. By March 2021, obviously we were getting quite frustrated that no progress is being made, and that we made an Official Information Act submission to Pharmac, and we questioned their analysis and how they accounted for the benefits to patients and their whānau or family, and the cost to the wider health system. And with Pharmac's processes at that point, those considerations don't get taken into place. And again, they just reconfirmed that they didn't want to be spending more than what they were currently spending on Gilenya. In their response, they advised that Pharmac had not declined the funding application for cladribine, but it remains an option for investment for Pharmac. However, it's not currently a working priority. One of the issues in New Zealand with the Pharmac process is that once a treatment is under consideration, you can't apply for a NIPA, an MPPA, which is a named patient application, and that for the indication which an application is for, so no one can actually get onto treatment for it. And as mentioned, Merck have made 3 failed attempts to price match. Last month, Merck presented some updated evidence to Pharmac regarding the 4-year retreatment data, which is under 10% of treated patients. Pharmac's costings were working on a 20% retreatment rate, so we're hoping that that will have some influence and change that there. Along with the latest evidence around safety and efficacy, and people remaining on treatment with cladribine longer than they do with other treatments. Merck have made a supplier resubmission, which is going to PTAC's November meeting, and by Friday we are making a supplementary submission highlighting the consumer perspective of the treatment. Obviously, we'll be really focusing on that once yearly dosing for 2 years, and how this impacts health-related quality of life, and also, of course, alerting them to WHO's recommendation on the EML, which I'm aware is also in Merck's submission, so they've highlighted that also. And we'll also be expressing our continued disappointment at the lack of transparency with Pharmac's processes. The delay with the process is very much that the cost of Gilenya is a hidden cost, and so any attempts to match that have been unsuccessful. Thank you very much.